Hello and good evening, everyone. This is Dr. Rajat Jange, President, Indian Cartilage Society. And today evening, I would like to welcome everyone for the fourth webinar of Indian Cartilage Society. And we have been doing this webinar since last 3 months, and we have covered various topics. And in this webinar, we invite different specialists. Hello and good evening, everyone. This is Dr. Rajat Jange.
I can go ahead, Dr. Rajat. There is no echo. You're on mute. You're on mute.
So in this webinar, we cover one topic of the basic science and another topic of clinical science, that is the orthopedic surgery. So we have various specialty from the world, and we have done the webinars very successfully since last 3 months. And to moderate today's webinar, I would like to invite Dr. Sasinder.
Thank you very much, Dr. Rajat. We would like to share that we are on the fourth webinar of the Indian Cartilage Society. So, as Dr. Rajat said, we will be discussing some very basic topics to understand the basic science that is happening behind cartilage repair and cartilage injury, and also the clinical or surgical management part of it. So today we have some interesting discussion going on. Our faculty for the basic science is Dr. Pan Chong. She is senior lecturer from University Malaya, Malaysia. Welcome, Dr. Pan. She has been associated with Indian Cartilage Society for a long time. She has served as faculty with Indian Cartilage Society, and she is a well-known figure in basic science of cartilage. We welcome Dr. Pan Chong to speak on cellular behavior and matrix interactions in matrix-induced chondrocyte implantation. But before that, we'll have a short discussion or interaction between Dr. Rajat and Dr. Pan Chong. Over to Dr. Rajat.
So welcome Penpeng Chong again to Indian Cartilage Society. You have been the faculty in Jaipur Congress as well, and we have also invited to you in other activities of Indian Cartilage Society as well. And you know, you are a good friend of me since long, and we have interacted a lot. So today, I think we are going to have your experience about the basic science in cartilage repair. So please share a few details, what kind of work you are doing, and to the which kind of institution you are associated in Malaysia.
Okay, first of all, I would like to thank the invitations from the ICS, especially Dr. Sasi and Dr. Rajat. So actually, I already involved in the cartilage regeneration for about 20 years. So I started my PhD focused on stem cell, and then we try to use the stem cell to repair the cartilage. I start my work using the in vitro using the lab cell culture, and then followed by the animal work. So recently, we try to develop something we call PEV, platelet-derived extracellular vesicle. So it's some sort like the PRP, but PRP, they just use the platelet. So we use our in-house technology. We already patented this technology. We use our in-house technology to something like manipulate the platelet become a smaller vesicle. So we call it as an EV, extracellular vesicle. We use this to treat our OA patients who are in the stage 1 and stage 2 OA. And then so far I attached at the University Malaya. I also quite active in Malaysia Orthopedic Society. And I also the committee member under the OSCE. So last year was my sabbatical. So I obtained the travel scholarship from OSCE for me to continue my training or attachment in Auckland University, Michigan, US. under the supervision of Professor Yang Xia. He is the famous physics in imaging of the cartilage.
So thank you, Peng Peng, for that introduction. So I think today we can proceed with your presentation.
Yeah, okay, sure. Let me share the screen first. Can you see my screen?
Yes, please.
Yes, clear.
Okay, thank you. Okay. So good day to everyone. So today, I would like to share with you the cellular behavior and the matrix interaction in matrix-induced chondrocyte implantations. Just a little bit introduction about the compositions of the articular cartilage. There's about 70 to 80% fluid, 20% cellular matrix, include the pericellular, extracellular, and only 1 to 2% chondrocyte. So this is the traditional cartilage regeneration technique. So if let's say the patients have the full thickness focal contra lesions, the lesion is depleted to ensure healthy, stable margins for integrations of the host tissue with the new tissue. So the alternative, the regeneration technique can be microfracture, means the surgeon use the surgical tool to mix the hole on the subchondral bone so that the bone marrow or the stem cell can be released out. And then we also have another technique called ACI, Autologous Chondrocyte Implantation. And after that, they use another scaffold that limit as messy matrix-assisted ACI or matrix-induced chondrocyte implantations. So basically, for the messy, first, the surgeon have to harvest a small sample of the healthy cartilage from the non-wet bearing area of the patient joint. Then this tissue sent to the GMP lab for the processing. The technicians have to isolate the chondrocyte from the cartilage and culture it in vitro in the lab, which take about 3 to 6 weeks. After the cell are expanded, they need to maintain their chondrogenic differentiations. After that, all the cells will be seated inside a scaffold, so they can be a biodegradable 3D scaffold matrix. This matrix is to provide the supportive environment for the cell and to maintain their functions and structure. This contract is pre-incubated so that they can promote the cell adherence and proliferations. The last step will be the surgeon have to implant this cell-seated matrix into the cartilage defect size and then screw the place with the fibrin glue. So this construct will regenerate the new cartilage tissue. This is the timeline for the significant events allowing the evolutions of the ACI to the current form. So as you can see here, the first surgical trial of ACI in rabbit was in 1989, followed by the first surgical trial of ACI in human by Brickford, consisting of autologous chondrocyte injections under a periosteal flap. Then after that, around middle of 1997, commercial use of collagen 1 or 3 porcine membrane. After that, in 1999, introduction of MESI, a collagen scaffold for chondrocyte suspension. So in 2000, Cartilage provided the first commercial source of the ACI. After that, in 2014, commercial use of the MESI begins to rise as it entered the market. So MCI basically is the third generation. So the latest generation, they try to use the alternate cell source instead of the chondrocyte, for example, mesenchymal stem cell, induced pluripotent stem cell, human embryonic stem cell. And they also, for the culture condition, instead of using the FBX fetal bovine serum because it may cause the mad cow disease, they try to use the PRP, platelet-rich plasma, and maybe substitute with the growth factor such as TGF-beta and IGF. And they're using different type of scaffold, for example, collagen, hyaluronic acid, or PLLA. So doesn't matter it's messy or even the fourth generation, basically there is 3 main components when we involve this tissue engineering, which are cell source. You can use either the mesenchymal stem cell, chondrocyte, iPSC, or HEC. And all the cells are seated inside a scaffold, can be a natural scaffold or the synthetic scaffold. And with this combination, they need a culture condition. They use the media with the PRP and then addition with the growth factor. So for the chondrocyte phenotype and redifferentiation, we know that the chondrocyte is the native cell inside the cartilage. So basically, their phenotype is a rounded cell shape. They produce the cartilage-specific extracellular matrix, especially type 2 collagen. Agrican is a major proteoglycan and low proliferation capacity because of the also because of the high metabolic activity. And we always talk about the dedifferentiations, means during in vitro expansion, especially when we culture the cell in a 2D molar layer, the chondrocyte tend to dedifferentiate, which means they become fibroblast-like shape. They lose the expression of cartilage-specific genes or the marker, such as the type 2 collagen, and they begin to express the type 1 collagen. So the characteristic is of the fibroblast tissue. So in order to restore their cartilage forming ability, this dedifferentiated chondrocyte must be redifferentiated. This can be occurred by placing the cell in a 3D environment that mimic the cartilage ECM. So for example, hydrogel, scaffold, collagens or HA, and with the high density pellet culture. So redifferentiation is marked by the re-expression of the type 2 collagen and agrican, and then reduce the type 1 collagen expression. ECM also play a very important role in the chondrocyte behavior. Basically, ECM is not just the structure, it's bioactive and play a critical role in influence in the chondrocyte behavior. Their key roles including phenotype maintain. The component is like the type 2 collagen, hyaluron, and proteoglycan provide the biomechanical and biochemical clues to support the chondrocyte phenotype. And also the mechanical signaling. These ECM signals and convolutions influence chondrocyte activity through the mechanotransduction. And cell organizations, ECM architect affect the cell alignment, morphology, and matrix depositions. Redifferentiation signal. So ECM-based scaffold in messy and tissue engineering induce redifferentiations through the biochemical and mechanical cues. Besides the ECM, we also have another called PCM, pluricellular matrix. And this PCM basically is a specialized microenvironment that immediately surrounds the chondrocyte. So it's considered the innermost zone of the cartilage ECM and serves as the interface between the cell and the surrounding territorial or the interterritorial matrix. PCM also referred as a control capsule. And this component of PCM are rich in type 6 collagen. So this is the key structure component of pelican, biglycan, decorin, fibronectin, laminin, hyaluron, or link proteins. So this picture shows how the chondrocyte basically is placed at the needle with the nucleus in the needle and surrounded by the pluricellular matrix. And this PCM link the chondrocyte together with the extracellular matrix. For the clinical maxi outcome, so usually the surgeon will look for the histological markers such as collagen type 2, agrican, or maybe the clinical outcome we will use the MRI or some scoring like the course IKDC. And we also will follow up with the long-term tissue integration using X-ray and also MRI again. However, how we know in the cellular and matrix interaction between the chondrocyte. So that's why we have decided something with this project, mechanical compression controls the biogenesis of human osteoarthritis chondrocyte in vitro. So as you all know, OA can have different stage. When the patient in the stage 4 or in the last stage, they have to go for the total knee replacement. So usually the surgeon will just discuss the worn-out area. We collected this area for our further study. So just show you how the explant look like. Basically, there is a cartilage on top. The cartilage has different layers: superficial, middle zone, and deep zone, and then followed by the calcified cartilage, subchondral bone plate, and the subchondral bone. So in this study, we have collected the proximal tibia of the patient with the OA undergoing the arthroplasty, 20 sample, and the cadaveric donor as a single osteochondral unit, 5 sample as a control. So we study about the interplay of the highlight cartilage loss and subchondral bone changes using the high resolution peripheral quantitative computer topography. Basically, it's an imaging tools. And after that, we study the cartilage degenerative region. We divided into grade A, grade B, and grade C, followed by the density of the bone volume of the subchondral bone plate and the trabecular subchondral bones were measured. We also performed the gene analysis for the isolated osteochondral unit chondrocyte using the RT-PCR method and performed the histology staining using the Safari O. After that, we seeded this osteoarthritic chondrocyte into a bioreactor. Then we compressed this chondrocyte with the scaffold, 3% agarose scaffold, with the 10% or 20% uniaxial dynamic from 4 days up to 8 days. Then we studied the image that we received using the image J. So from the HRPQCT, the imaging, as you can see, at the subchondral bone region, the circle area is our region of interest. Basically, there is we divided it as a grade A, grade B, and grade C. So through the bone mineral density analysis, we noticed that there is a significant difference when there is a normal grade A compared to the grade C erosions of cartilage down to the bone, and also a significant difference when the grade B, either softening or swelling of the cartilage, or fragmentations or fissuring of an area that does not reach subchondral bone, compared to the grade C erosions of cartilage down to the bone. So for the Safari O staining, we can see there is the isolated chondrocyte still can express the proteoglycan, which stain in the something like pink red color. And we also perform the gene expression analysis. So all the OA chondrocyte, they still can express the cartilage specific gene. So now we all harvested the chondrocyte. We seated inside the these agarose. We choose agarose because agarose is the scaffold that can be compressed. Some of the materials like some of the material, they are not compressible, but once you compress, they will be collapsed. That's why we use this agarose. So we seated all the cells inside this agarose scaffold. The size is 5 mm by 5 mm, and then we put inside this barrier, compress this vertically, as you can see in the pictures here. So from the SCM, we don't see any obvious macroscopic changes. Basically, they're just a round shell shape. We can't see any differences. But when we perform the Safari O staining to stain the proteoglycan, we notice that when you compress longer, it will secrete more proteoglycan. Even you are not compressed, right? Actually, the cell is still can secrete the proteoglycan as well. So for the PCM, just a reminder, PCM basically is just the matrix link between the chondrocyte with the ECM. So we label the nucleus of the chondrocyte using the blue staining, and collagen type 6, the PCM, using the green staining. So you can see that the collagen type 6 was secreted surrounding the nucleus. From here, we compress the chondrocyte and we show that there is more intense and broader decompositions of collagen type 6 compared to the control. And the duration of the compressions was directly proportional to the intensity value of the collagen type 6. So basically, 8 days compression was significantly higher than the 4-day compressions, and 20% compression gave the significant higher intensity compared to the 10% compression in both 4 days and 8 days. So in conclusion for this study, treatment for OA actually should be target both, which are subchondral bone and not merely the cartilage alone. And the joint can be enhanced using the selected compression biosynthetic activity of human chondrocyte from the osteoarthritic region. So for example, we can encourage the patient go for exercise, for example, swimming. So this is something the new development for the Messi. So Desa in 2023, he published this sandwich technique. So basically, he used the Messi in the middle layer with the autologous chondrocyte, and then at the subchondral bone, he put in another autologous bone graft. So basically, it's the bi-layer treatment, chondrocyte and also the osteocytes. So this is our ongoing project. As I mentioned just now, actually exercise or biomechanotransduction is quite playing an important role when we treat for the OA patient. So this is our ongoing. I hope in the future I can share the outcome with you all. So basically we treat the ACLT rat, the OA rat using the treadmill. So in conclusion, MACI is a promising cartilage repair method. Cell behavior and scaffold design are critical. Future direction aim for personalized therapy. And the future direction should be bioprinting, means we depends on the defect area. We can just use a bioprinting, print out the exact area so that the surgeon is easy to implant the scaffold into the defect area. And this MESI, we can use the stem cell base instead of using the chondrocyte. Control release system means we can just encapsulate something like the small molecule extracellular vesicle with different bigger size, smaller size. So as we all know, smaller size have faster penetration. Gene editing application, we can use the microRNA which involved in the gene regulations as well. So if you need any further information, please feel free to contact me. Thank you for your attention. Thank you.
Thank you very much, Dr. Panpan. That was a very informative presentation. I have a lot of questions to ask, but I can ask you a couple of questions right now. Like, first of all, I do understand, and I would like to stress that it is not possible to repair the cartilage or reconstruct the cartilage without giving adequate respect to the extracellular matrix. We need to understand, I mean, the younger surgeons should understand that just putting cartilage into a defective area is not going to give you three-dimensional cartilaginous structure there that can bear weight and do the job of cartilage. You can't just put chondroblasts or chondrocytes there to get cartilage. You need to respect the interaction between the cell and the extracellular matrix. And thank you for explaining what exactly happens. And your study is quite interesting. Thank you for sharing the results. But I would like to raise a question. We mostly are involved in cartilage repair primarily for focal chondral defects, not for osteoarthritis. Most of the times, at least, we don't prefer autologous chondrocyte implantation. We prefer orthobiologics, which is a totally separate field for osteoarthritis rather than cartilage regeneration per se. But what I understand from your study is a combination of cartilage repair techniques and subchondral management can improve osteoarthritis. Is it what what is the clinical implication that you are trying to see from your study?
Okay. Um, Osteoarthritis is more to like degenerative disease. Focal cartilage defects maybe is something like sport injury. Basically we just want to reconstruct the cartilage. Then we need to say actually the treatment that we give to the patient is repair or regenerate the cartilage is two different things. So actually my study more to osteoarthritis. So we talk about how can we repair. Repair means is something like it's just something like temporary. We are not really regrow the cell. So the most common, the well-known one is something like PRP. So we just try to get the patient no pain, no pain, and some of the PRP they can partially involve in repair the cartilage. But if you really want to talk about to repair those focal cartilage means they're worn out already, no more cartilage. We need to repair. Then definitely we need to involve the cell. Definitely we need the chondrocyte. So there is no doubt that ACI is good. But the only problem is ACI is invasive. That means we need to harvest the cell from the patients. When we harvest the cartilage, means we also damage the healthy cartilage as well. So that's why the new trend, they try to propose something, use the stem cell. From this stem cell, they also try to induce the stem cell become the chondrocyte, then only implant. So this is something like the technology keep on moving on. SCI definitely is good. It's just only because it's invasive and may cause the donor side mobility.
Dr. Rajat?
So, Peng, excellent presentation. I think you have given a good insight into osteoarthritis. But as Sashi mentioned that most of the cartilage lesion, the focal condyle lesion, we are aiming at healing of the lesion. Other than that, we are just aiming at the symptomatic relief or the treatment of the osteoarthritis. So, being a basic research scientist, can you just explain to us, what is the changes that happens in the cartilage with the aging? So what happens to the cells? What happens to the ECM? So what are the things that is different in osteoarthritis and a focal condyle lesion? What happens to the cartilage with aging?
Okay. For the aging, usually is the old patient, OA patient, usually they are old, more than 50 years old. The problem for cartilage is cartilage itself have no air vascular. It's air vascular. Also no nervous. Means once the cartilage damage, it won't send the signal to our body. It's just like I'm holding a very hot water. So my body cannot feel. My finger is burning already. So by the time when my eye can see my finger burn already, it's already too late. So this is the same problem like the aging the cartilage. By the time when the patient they feel the pain, means already no more cartilage, bone to bone erosion. So this is a problem. Cartilage itself cannot heal because have no blood supply, no nerve there. So we only can feel when there is a serious contusion, when there is a inflammation or bone to bone erosion. So this is the difference. That's why OA usually is the degenerative disease. Meanwhile, the focal cartilage is because of the spot injury or the cartilage detached, and then the patient feel a very pain. So this is a different thing.
Dr.
And
Sumit
maybe
has a question to ask. Yeah, Dr. Sumit.
Yeah. Hi, Dr. Chong. Wonderful to hear from you. It was a very interesting and a very sort of mesmerizing kind of a study. I just, again, all our questions from Sasi to Rajat, all our questions tend to be that because most of us tend to do cartilage repair for the focal defect. So now this question is regarding when you're trying to, as you said in your study, when you're trying to do that sort of that bone graft plus the double layered sandwich kind of a technique. So most of the time when we're trying to treat a chondral defect, we are trying to create a very contained sort of a defect, right? Where we very sure that the boundaries are contained, then only we can put in the cartilage cells and the matrix. Now, with a degenerated joint, wherein there is a widespread global kind of a degeneration of the cartilage, how do you maintain that sort of that boundary, or how do you decide how to sort of contain and concentrate that Macy layer into that, because there is no one defect, it's global all around. And the second part is that, again, the focal defects tend to be on one side. Here, the degeneration would be both on the femoral as well as the tibial side. So, does that play a role in the outcomes, or do you modify your protocol when sort of implanting those cartilage? Thank you.
Okay. Actually, my team, we also have conduct some in vivo. We using the animal. We also we harvest, the means is a control, is a how to say, is a ultra control defect. So we also something like remove the cartilage, and then we use, because a rabbit knee is quite small, so we used our stem cell. We use stem cell, mesenchymal stem cell. We seed the stem cell into the alginate. Then we transplant. So it depends on the area of the defect, the control defect area. If let's say big, we put more alginate bit. So we use this stem cell seeded alginate bit to repair the osteochondral defect as well. So the outcome, based on our experience, if you want to get a better outcome, you need a longer treatment. So the time we compare 3 months and 6 months, the 6-month outcome definitely is better than the 3 months. And most of this kind of osteochondral defect repairing, most of us, we worry about the outcome maybe is just something like fibro cartilage, right, instead of the highlight cartilage. Am I right? Right. So most of the outcome they say is a fibro cartilage. They are not as bad as the highlight. But based on our experience, we use the stem cell. Actually, after 6 months, but we only monitor up to 6 months for our rapid work. After that, we perform all the histological, we perform the CT scanning, morphological scoring. We notice then it's more like the highlight cartilage. It's not a fibro cartilage. So that's why we are also quite happy with the treatment outcome using the stem cell. And then a second question is
The kissing lesions. When
sorry?
you have the degeneration on both sides, both the femoral as well as the tibial side, not just one-sided degeneration. When you have both side degeneration, then also does the same protocol work, or do you sort of modify it, and how are the outcomes?
Okay, so I'm really sorry for both sides, because we are not we so far we don't have any experience in one knee, femur and tibia. But we study with one animal, left and right. So left and right are contralateral and ipsilateral. We notice that actually the knee may be at worse condition, actually is at the contralateral, not the ipsilateral. But if let's say in the same knee, femur and tibia, this one we have no experience.
So, being a surgeon, may I answer his both questions? So his question was regarding the sandwich technique you described. So the sandwich technique is very well popularized by Dr. Deepak Goyal, and it's a overlay ACI technique he has described. So for if the patient is having a subchondral bone defect, then if you want to apply an ACI, so if the lesion is more than 4 millimeter of the subchondral bone, then you need to bone graft it, then you can apply an ACI on top of it. So if the lesion is less than 4 millimeter, the ACI will take care of the subchondral bone itself. So in that case, you can do only ACI. And the second question he mentioned is the bipolar or the kissing lesions. So, previously it was considered to be a relative contraindication for the ACI procedures, and in my personal perspective, I don't use the ACI for bipolar or the kissing type of lesions. But in literature and few surgeons, they have used it for the bipolar or the kissing type of lesion on the femur and the patella, femur and the tibia as well. And we are still awaiting the results in terms of literature.
Okay. Because actually so far my experience only in tibia. We don't have any experience at the same time femur and tibia.
Yeah. So we had an excellent discussions with you, Penpeng, and
Yeah,
now
thank you.
we'll move ahead with the next talk. That is so
Yeah,
Sashi.
so we invite Dr. Rajat to speak on gel-based autologous chondrocyte implantation, which is a type of matrix-assisted autologous chondrocyte implantation. What are the evolving techniques and the clinical outcomes? Dr. Rajat. Dr. Rajat is the president of the Indian Cartilage Society and a well-known cartilage reconstruction and arthroscopy surgeon from India. Over to Dr. Rajat.
Thank you, Sashi, for that introduction. So, so my screen is visible to you.
Yes, clear.
So, today we are going to discuss about the gel-based autologous chondrocyte implantation, the evolving techniques and clinical outcomes. So, in India, when we started with the ACI, it was the first generation ACI having the periosteal patch and the chondrocyte. So, and in between it was amended for a few years, and since 2014 or 15, we have started it again, and it's a gel-based ACI which is available in India, and we are doing this since last 10 years or so. So the journey of the cartilage repair started with this famous saying by John Hunter that the cartilage injury is troublesome thing, and once injured, it seldom repairs itself. And since then, we are chasing this holy grail, and we are in search of the ideal cartilage procedure since long. And there's more than right answer for the same thing. There are multiple procedures that have been described in literature, from debridement to the microfracture, OCT, and ACI. So the debridement and microfracture, these two things leads to the fibrous kind of repair, and the results are very short lasting. It can be done in a low physical demand patient with a smaller size of the lesion. The OCT and the ACI, they leads to a hyaline cartilage of repair, and it can be done in a high physical demand patient and also for a large size lesions, and the results are also durable. The ACI first done by Professor Mats Bidbug in 1994, and since then the ACI has evolved over a period of time. The first generation ACI had a periosteal patch. Under that periosteal patch, we need to insert the chondrocyte culture. And the second generation of the ACI that had the collagen patch. So under that patch, the chondrocyte, they survived and they grow. And the problem with the first and second generation ACI is the suturing of that collagen and the periosteal patch that makes the surgery longer, and also it makes the procedure morbid. And another problem is the monolayer distribution of the chondrocytes. So what happens with the monolayer distribution of the chondrocyte? The chondrocyte growth is slow, and also the dedifferentiation into the chondrocyte is difficult, and more so the collagen that shift from type 2 collagen to the type 1. So we are aiming towards the type 2 collagen repair. So that happens with the monolayer distribution of the chondrocyte. But in the third generation and the fourth generation ACI, they use the collagen matrix, or the fourth generation uses the scaffold, the third generation using a fibrin glue fixation. So these two type of third and fourth generation ACI, they are using a scaffold that leads to a 3D distribution of chondrocyte. So what happens with 3D distribution of the chondrocyte is that it leads to a more viability and equal distribution of the cells, and it leads to a faster growth, also a three-dimensional structure of the chondrocyte in that scaffold. There are different hydrogels matrix that are available. One which we are using in India is the fibrin gel. It is biocompatible and it forms a three-dimensional structures. Another one is the hyaluronic acid that supports the chondrogenesis. It leads to cartilage formation. There are different gels that are available that forms a 3D scaffold, and it promotes the cartilage. And the chondrocyte which we have cultured from the laboratory, it can survive in a three-dimensional structure, and it leads to more so a hyaline like cartilage repair. So what is the rationale for a gel-based ACI? It is injectable and it ensures the even cell distribution is also avoids the mechanical trauma in terms like a periosteal, sleeve suturing. It reduces the surgical time, it reduces the delamination risk, and it leads to a enhanced integration and also improved biological signals to the chondrocyte and improved cartilage healing. What are the indications for the ACI? Symptomatic. The patient has to be symptomatic, and only an asymptomatic patient and in expectations of the disease progression, it is not recommended to do an ACI. Focal condyle lesion, we can do an ACI. The full thickness defects, 3 or 4 ICRS grade. Typically, the large size lesions more than 2 to 2.5 centimeters square. Even the people have used more than 10 centimeters square size lesion as well. Typically the young patients and high active patient, those are the candidate for the ACI. Before going for any cartilage surgery, you need to treat the alignment first. If there is a malalignment, you need to treat it with osteotomy or some procedure. If there is a meniscus deficiency or a meniscus tear, you need to repair it. If there is an associated instability, you need to repair it. And there are definitely certain contraindication to the ACI as well. Advanced osteoarthritis. So if there is a grade 4 kissing type of bone-on-bone disease, then you need not to do an ACI. You can just do an alignment correction in this patient or a TKR. That is enough. And if there is a chronic infection or the patient is on immunosuppression or rheumatoid inflammatory arthritis, in those cases, ACI is contraindicated. And with my own experience, I've learned that the OCN, the osteochondral necrosis patients, if those lesions are progressive, that means you have seen the patient and it is likely to progress in near future. So try to get the patient when the patient is having the maximum disease progressed. So that means that there is some hold to the disease and it is not progressing for some period of time. Follow the patient for a few years. Then you can go for subchondral bone grafting and the ACI, that is the overlay ACI. But if you do ACI in those patients where the disease is progressive, then you will treat the patient partially only, and the patient will come to you again after a few years with a failure. So try to do in the patient where the disease has halted for few more years. And those patients, those are not compliant to the rehabilitation, those are smokers and obesity. So these patients are likely to heal, not to heal well in this patient. So I will try to demonstrate a case here. This is a 23-year male patient, anterior knee pain since 2 years, and the pain is more during the activity of playing. And this is increased with the prolonged sitting and also stair climbing. There is no history of trauma. The patient is a professional boxer and he has the patellofemoral crepitus. Other than that, there is no instability. Other clinical examination of the knee is normal. So this is the MRI of the patient. We can see a full thickness condyle lesion at the patellar apex. So if we see this patellar apex, this is the most thickest cartilage in the body. The cartilage here is approximately 7 to 8 millimeter thick. So if we compare it with the femoral condyles here, the cartilage is 4 to 5 millimeter, and on the periphery it is 3 to 4 millimeter. So there are very high amount of stresses here, and also we can see a subchondral small cyst here as well. So this cartilage is quite different. So treatment of the cartilage lesion on the facets here and the treatment of the patellar apex is quite different since the forces are quite more. So in this patient, also it is very difficult to match the contours if we try to replace this with the osteochondral cylinder transfer from the lateral femoral condyle non-weight bearing portion. So OCT plugs is hardly having a 3 to 4 millimeter of the cartilage. Here the cartilage thickness is more than 8 millimeter. So it is very difficult to match the cartilage thickness as well, and also difficult to manage the contours at the apex as well. So this is possible with the ACI. So we have done the ACI in this patient. We have counseled the patient that you are going to require a 2-stage surgery for this, since this is a lesion at the patellar apex. So first stage is the biopsy that we need to take from the same site. We harvest the osteochondral cylinder transfer, that is a lateral femoral condyle, or we can take it also from the medial femoral condyle anterior non-weight bearing portion. And it is essentially an arthroscopic biopsy. We use the same harvester what we use for the osteochondral cylinder transfer, and previously we used to send a 8 millimeter plug, and this should have at least 10 to 12 millimeter of the subchondral bone with itself. And this cartilage is grown in the laboratory for 3 to 4 weeks. And after that, they will confirm the cell viability, cell count, phenotypes, whether it's a cartilage that has grown. Sometimes it's not possible to grow the cartilage despite the fact that you have sent the sample. So they check it for the cell viability and whether it is a cartilage or not. So in this patient, after 4 weeks, we did the biopsy in January 2017, and we received the cell in February after 4 weeks. And these are the adult live cultured chondrocyte. They come in this vial. They are transported with a cold chain maintenance to us. And in every every ml, we have a 10 million cell. That is 10 million cell every ml of this cultured chondrocyte gel, and it can be up to 60 million. And the 1 ml fills the defect in the 1 centimeter square size. So if you need a more chondrocyte for a larger defect, then you need to tell your supplier that I have a lesion size that is approximately this much size, and I need some additional cells. So in that case, they can supply you some additional vial as well. So these are two syringes. One syringe is filled with the fibrin, another syringe is with the chondrocytes. And these are the different instruments that are available with me during my surgery. So we have these different sets of sets for the debridement and also the other procedure that require for the cartilage ACI implantation. The second step of the surgery was done in February 17. And the surgery can be done arthroscopic or open. But since patella, you need to invert the patella. So it is essential that you need to do an arthrotomy. It is essentially a medial arthrotomy for patella. And you invert the patella so that this gel is, by the effect of gravity, is not spilled in the joint. And you can do it arthroscopically also for the femur. But for patella, it is essential to invert the patella and do a mini arthrotomy. So first thing is to assess the size of the lesion primarily. This is not the definitive size of the lesion. This is just at the initial point. And this appears to be approximately 8 into 8 millimeter size. So the final size is going to be after the debridement only. So since it was a small size, 8 into 8 millimeters, so I've used the OCT plug harvester to debride the defect. So it gives me a smooth rounded contour to me so that I can implant the ACI well. So it was a 8 millimeter size cylinder, but you also need to check the integrity of the surrounding cartilage, whether this cartilage is also soft. So even if after your full debridement, the surrounding cartilage is soft, you can do more debridement. Like in this case, when I did check the surrounding cartilage, this was also soft. So I checked the surrounding cartilage. So it was soft also. So then I further extended my debridement. So after that full debridement, the defect size was approximately 1.8 into 1.2 millimeter size. So this was near the apex after full debridement. Since this was not involving the subchondral bone more than 4 millimeter, so I didn't do any bone grafting to this. Since it is mentioned in the literature that if the the subchondral bone involvement is less than 4 millimeter, you can just do the ACI implantation. So this is the syringe which is supplied with the chondrocyte culture. So in the one syringe, there is a fibrin glue, and in another syringe, there is the chondrocyte culture. So you need to pour the ACI culture drop by drop. So the fibrin glue settles the chondrocyte. So this is settling in. You need to be very slow and wait for the drop to settle down. And this is after the final implantation. So we can see that there is a smooth contour of the cartilage that is covered. So this is not possible with the OCT, and this is possible with the ACI only. And after you have fixed your ACI, you need to pass the knee through the gentle range of motion, and you need to check for the stability. So you just need to do 3 or 4 knee bending and gently pass it through the range of motion. So if everything is stable, then you can proceed with the closure. And we can see this is very much stable, and we have done the post-operative MRI at 1 year. On this MRI, we can see the thick cartilage that is grown over the ACI implantation, and subchondral bone is also covered. There are some artifacts inside this grown cartilage, but we can make out that with the manufacturer that there are certain cartilage things that are there in the MRI, but this eventually stops with the maturation of the graft in subsequent years. And if you will follow the patient for a few more years and do an MRI again, then this is going to be very, very thick matured cartilage in the following years. And we have done this case in 2017. And after we have done the follow-up since last 7 years, but this is the last follow-up. This is a boxer, and he's doing all the sporting activity since last 5 years. So this is a very successful outcome of this patient. And our own experience about the ACI is a small case series of 7 cases, 7 cases in femur, 3 cases in patella. We have evaluated our patient with the Lisson and Kuzala scores, and the minimum follow-up is 1 year and the maximum follow-up is 7 years. And the outcome with these scores have been good to excellent. We need to look for the evidence which is available for the ACI since it started in 1994 with the Professor Metz Bitberg, and Metz Bitberg used it for the full thickness chondral lesion, 1.6 to 6.5 centimeters square size of the lesion in 16 patients. And out of the 16 patients, 14 patients had good to excellent outcome at 2 years. And he has taken the biopsy in second look arthroscopy as well. He has mentioned in the literature that the cartilage which he has grown was somewhat harder in nature, but on biopsy, it appeared to be a hyaline cartilage. So we have honored Professor Matt Spitberg for his work in cartilage repair by Lifetime Achievement Award in Masterclass in Cartilage Repair 2 by Dr. Deepak Goyal this year only. And 2010. So since 1994, there has been a lot of research in ACI after that. And there is a review paper in 2010, 626 patient, 1 to 22 centimeter square size of lesion. And they have demonstrated the good clinical outcome in these patients. But there is no sufficient data that whether this technique is superior to the other techniques. But the absence of evidence, that means absence of data, doesn't mean that there is no evidence. And further studies are required to evaluate whether this is superior to the other technique like microfracture and OCT. So in 2016, there's another review paper. Since these surgeries are not done extensively, not done regularly, so only the review papers that can suggest to us whether the evidence exists or not. Even the randomized control trials have been done, but those are having very less number of patients. So level 4 evidence, systemic review of 1 to 4 studies, 115 patient, 0.6 to 5.3 centimeter square size of the lesion. They have used all the generation of the ACI and they have demonstrated a good clinical outcome. And the adverse outcome which was available with the first generation ACI was 7% of the patient had the graft hypertrophy or the periosteal patch hypertrophy. If we compare the ACI with the microfracture, the evidence in 2016, both of them had the short-term good clinical outcome at 2 years. But there was no difference macroscopically or histologically. There is no association between histological findings and clinical outcome at 2 years. Since this study was only done for 2 years, I think we cannot say that there is no evidence of superiority or inferiority of ACI over microfracture. Then came another review in 2019 that included the ACI with the collision patch and the Messi. They had the review for more than 5 years. So they have shown the superiority of ACI over microfracture if followed up for more than 5 years. So at 5 years, this durability of the ACI over microfracture and the effect of the microfracture, they do not last more than 2 years. Then since then, there had been many reviews about the ACI, and these reviews suggest that there's enough evidence at present and there are mid-term to long-term good results with the ACI, though the patellar ACI have done inferior to the femoral ACI. But the problem with those papers was that these papers use the older generation of the ACI, and also there was no biomechanical correction done in these patients, in these studies. So the recent studies with the third generation or fourth generation ACI and with the biomechanical correction have demonstrated the similar kind of result in patellar and the femoral ACI. The advantage with the ACI is that the recent third generation ACI is that there is no need to use a periosteal patch or collision, and there is no need to go for a size and shape match. It takes the shape of that lesions and it distribute the chondrocyte in 3D. There is a better cell distribution, better cell growth, greater viability of those cells. And also, since you are not using any collagen, there is less type of immunogenicity and also faster surgical. There are limitations of the study. That is the two-stage. The ACI is a two-stage surgery. It involves cost and complexity, and it is not ideal for a bipolar kissing type of lesion, and especially for athletes. Those are not willing to go for longer rehabilitation period. So if the athlete is not willing for a longer rehabilitation, he wants to go faster. For a mid-sized lesion, it's better to go for a osteochondral cylinder transfer. And you need to counsel your patient that you will require a longer rehabilitation if you compare with the other technique, though the results are durable with the ACI. There are future directions. Those are the stem cells and the gels that have been described by Peng Chong. Bioactive gels, different control release of the growth factors, three-dimensional scaffolds, the hyalograft or the bioseed C, these are different three-dimensional scaffold that can be used. And today is the era of AI-generated cells, robotic delivery of these cells into the lesion. So I think these are the few things that the science is still progress. And after all, we need to manage our patient expectations and we need to know our literature, use our own experience, talk to your colleague. We have a successful outcome with even with the non-operative procedures, and we can have a poor outcome with the surgery as well. And you need to choose your patients wisely, choose your surgery wisely, Whether you are treating a focal chondral lesion or a degenerative cartilage lesion, you need to look for. Thank you. Thank you for your patient hearing.
Thank you very much, Dr. Rajat. That was an extensive presentation of gel-based autologous chondrocyte implantation. Thank you for covering the principles and also the outcomes of your treatment.
Hi, Rajat.
Hi.
Yeah, Dr. Sumit.
Thank you for the excellent presentation as always. And yes, as you have rightly said, all the pros and cons of ACI. So I just have one. Basically, it's a point of discussion rather than a question. Really, is that now, as you have said rightly, the limitations of it is essentially it's a two-step procedure, and the cost goes up, and the rehab time also goes up. So nowadays, with the advances in the stem cells and stuff, there has been a lot of talk going on about this single stage sort of delivery systems and using of BMAC, bone marrow aspirate concentrate, in treating mid to large sized lesions. So essentially, this is a discussion to all of us here that what is your thoughts vis-a-vis ACI versus a BMAC for a, let's say, a mid to large size lesion of focal chondral defect?
So I think we have two type of system while we are dealing with the large chondral lesions. One is a cell based, another thing is a scaffold based system. So in what happens with the scaffold based system, the surrounding cartilage cells from the natural cartilage, they grow into that scaffold. So it can be a chondrophila, it can be a hyalofast. So these things, the chondrocyte from the normal cartilage, they grow in and they mature. Another thing is the ACI kind of thing where we grow the chondrocyte outside and then it grows of itself or regenerate itself. So what you are talking about is the BMAC. It is a totally different thing and it has been used for the mid-sized lesions since long. But whether this is going to be successful for a large chondral lesion like 6 centimeter square or a 10 centimeter square type of lesion, there's not enough evidence, not even enough studies available at present that suggest that BMAC can be used for a large chondral lesions. And personally, I have not used the BMAC for large chondral lesion. And for the mid-sized lesion, it's okay. In mid-sized lesion, OCT works, the BMAC works, the hyalofast, other things work. But the surgeons, they have used for the large size lesion as well. But the BMAC, there are no long-term studies that suggest that the BMAC can be used for large size lesions.
Thank you, Rajat. So this question is also to Kanpan Chong also. As you rightly talked about the types of gels or the types of matrix that we can incorporate with our ACH in. So my question is, does the type of gel, how much of a difference does it make? So if you could, with your background in basic sciences, if you could enlighten us on that, how much of a difference does it make? What kind of a gel or a matrix we're using alongside our ACI?
Okay, thanks for the questions. Actually, for me, this is as I mentioned just now, this is three things. One is the scaffold, the gel, or the cell, or the growth factor. Actually, for me, I'm more concerned about the cell instead of the scaffold, the gel, because the one that really can help to regenerate the cartilage actually is the cell. And for me, one of the disadvantage to use the BMAC is BMAC basically is just a bone marrow concentrate. They just concentrate the bone marrow on it. But what we are doing is we have the bone marrow, then we isolate the mesenchymal stem cell. After we isolated the mesenchymal stem cell, then we proliferate the cell. So whatever that we injected to the either OA model, OA rat, or OA patients, or the osteochondrite defect, actually we are using is the pure mesenchymal stem cell. It's different as BMAP. And the outcome definitely using the pure, the homologous cell is better than using the something like heterogeneous BMAP. And for me, I feel the gel actually is just a carrier. It's just a carrier or scaffold, so that the cell can grow inside under a 3D dimension, and the cell can start to proliferate and secreted the matrix, either the PCM or the extracellular matrix. So that's why unless you are doing something like slow release, the gel itself also something like combined with different small molecule of the growth factor or extracellular vesicle and with the cell, then you need to consider what is the porosity of the scaffold. So how the cell can penetrate, how the small molecule EV can be penetrate, and how long the gel or the scaffold will be degraded after you implant into the patient.
Thank you, Pam. Thank you so much for explaining it so nicely. So, what I'm getting from you is that the primary thing is the cell, right? And if you're just relying solely on those, the differentiated chondrocytes, then the gel or the scaffold perhaps doesn't matter that much. But if you're wanting to incorporate other elements like the growth factors and stuff, then you need to consider the porosity and the characteristic of the scaffold. Is that right? Yeah.
Yes.
Thank you. Thank you so much for explaining it. Thank you.
Thank you.
I think this was a very interesting discussion, both about the basics and also about the clinical aspects of autologous chondrocyte implantation. Dr. Rajat, do you have any other questions?
I think we had a good discussion about the basics and clinical science as well. I think you may be having many questions. You usually ask many questions in the webinar.
I think it was all self-explanatory,
So,
and
Sasi,
the discussions were very
what are
good.
you using for large chondral lesion?
I'm sorry, Dr. Rajat.
So, what are the procedures which you are using for the large chondral lesion?
Okay, okay, so in my experience, I use a lot of cylinder transplants, oats, and I have used both BMAC and autologous chondrocyte implantation as well. As far as the lesions, with the size of the lesion is concerned, again, the patient profile also comes into picture. As in professional sports guy or relatively recreational type of sports person. My preference is becoming more cell-based unless I can completely replace the defect by one or two osteochondral cylinders. I do not want to take more than that, considering the donor site morbidity and also the possibility of not filling the defects completely. I think the literature has shown sufficiently good results with a lot of treatment options. Now the onus is on the surgeon or the clinician to effectively conduct the procedure considering the basic science aspects and the principles aspect rather than the treatment option itself delivering. I think the onus is on following the basic principles of the surgical technique rather than the choice of the treatment, because most of the treatment options provide similar results. I am not considering microfracture or abrasion chondroplasty as a treatment for cartilage lesions at all. I mean, in my opinion, they are not at all cartilage repair or regenerative techniques. So yeah, I do cylinder transplants. I also do BMAC and autologous chondrocyte implantation. Larger lesions, I prefer cell-based treatment techniques that include BMAC and autologous chondrocyte implantation. The difference between these two being the cost factor. Uh, I prefer BMAC more than autologous chondrocyte implantation, considering the cost factor, unless the patient is able to tolerate the cost. The other factor that might decide my treatment option is the amount of subchondral bone involvement. As I said, for more superficial ones, I tend to go more toward the cartilage chondrocyte side, and for deeper ones, more on the mesenchymal stem cell side.
So I think, Sashi, that is the standard practice. If you require more than three cylinder plug of 8 millimeter, then I think it's better to go for an ACI. So mid-side lesion, an OCT, or a large size lesion, an ACI. But I think we have discriminated with the ACI and BMAC so well that we expect the ACI to produce a hyaline cartilage in itself, but we have not compared and done enough studies for the BMAC, whether it regenerates the hyaline or a hyaline or even a fibrocartilage. We have not done the enough studies on BMAC. The BMAC, there is not much of the literature available. So I think we are discriminating with the ACI.
I think we have
I
sufficient
think, yeah,
studies to say.
there are studies. Yeah,
Yeah, we have sufficient studies
research
to
studies.
say, and there are studies to say that the outcomes of BMAC are no inferior to autologous chondrocyte implantation, but possibly the chances of intralesional osteophyte is possibly higher in BMAC than in autologous chondrocyte implantation, but it does not reflect on the clinical outcomes for the patient. So I mean, considering that the outcomes can be similar between BMAC and autologous chondrocyte implantation, and considering the cost can be as high as 2 times or 3 times with autologous chondrocyte implantation, BMAC appears to be more attractive. Dr. Sumit?
Yeah, so I agree with you. So there's a study by the Gobi group has done quite a few studies. They've in fact compared it to Macy itself and found that the results are fairly similar. And yes, I agree. On a principle basis, it still seems that the ACI should do better because you are putting in a differentiated chondrocyte cells into the defect rather than hoping that the bone marrow cells differentiate into a chondrocyte. However, on the clinical side, the results have been fairly good with BMAC as well. And yes, it is definitely a good alternative out there. Whether it is better than ACI or MACI or as good, that time will tell. I mean, we'll have to wait for more larger widespread use of it. But yes, it is definitely a viable alternative to consider, especially for your mid to large size lesions. And yes, as you said, the cost and the fact that it can be done in a single stage really do make it a lot more attractive options. As terms of protocol, yes, I agree. Most of all three of us probably following the same similar kind of a treatment strategy. Up to about 3 plugs, it's OCT is probably our workhorse, and beyond that, yes, depending on the patient's affordability, his uh, uh, demand status, we would probably switch between. I tend to do more of ACI. Let me be very honest. I'm more towards ACI than BMAC, but I'm slowly that proportion of BMAC is increasing a bit as well in my practice.
So Dr. Sumit and Dr. Sashi, I will counter you in this respect that you have the BMAC is subjected to the clinical outcomes. So we have studied the clinical outcomes of microfracture, non-operative treatment, ACI, BMAC, everyone. So in more of the studies, the clinical outcome of even a non-operative treatment is successful. The clinical outcome of microfracture is even successful for a few years, and also for the BMAC, the other thing as well. But the ACI is more extensively studied in terms of the clinical outcomes, long-term, mid-term, short-term, second look arthroscopy, histology. So different outcomes, they have been studied. Also the radiological outcome, the MOCART scoring. So the ACI have been studied in a different outcomes on a longer duration when we compare it to the BMAC. While BMAC have been studied, but only for the clinical outcomes of few second look scopies, but not extensively as the ACI have been studied since last 30 years.
I
Yeah,
agree, Rajat.
yeah.
I agree, Rajat. We are not arguing, we are discussing it, but yeah, we do agree with your point that ACI is currently the gold standard. I mean, principally and theoretically, and with the amount of sort of investigation and literature that has been done onto it, what we are saying is not trying to pit BMAC against ACI or something. What we are trying to say is that BMAC is a viable alternative. It is coming up as an
Yes,
alternative. It is
definitely.
definite. It is definitely something you need to have in arsenal. Can it replace ACI as of now? No, no, it cannot replace the ACI as of now. But it is a viable alternative. And yes, as the time goes on, we will have to sort of look at it, as you said, histologically, radiologically, with the MOCART staging, and all of that will have to come, and it will all have to justify whether BMAC is able to live up to that, level that ACI has been subjected to. I completely agree with you there. I mean, there is no question that as of now, ACI has been probably been more well studied, especially the second and third generation, the matrix based ones or the gel based ones are definitely been subjected to more rigorous studies and investigation than BMAC has. But yes, what we are trying to tell is that that is also an alternative we need to have in our arsenal, and we need to study it more. Maybe all of us need to probably do more research and studies, clinical studies comparing these two, so that we get good data from our centers as well on these. Thank you.
Yeah, I do agree with Sumit. ACI should be considered the gold standard, principally, and also because of the availability of literature evidence. So it is like the old senior person in the room.
Yeah.
Okay, so that's the gold standard, but doesn't mean that the younger people cannot match up to the older, more tested person. This is younger, that doesn't mean this is not good because the literature is not present. But I mean, there are outcome studies for microfracture, for abrasion, chondroplasty, etc., etc. The outcomes are always good. On the short run for microfracture and abrasion chondroplasty, there are midterm and long-term outcomes. At least midterm, we have a lot of midterm outcomes for BMAC as well. So BMAC is the younger person in the room. So obviously the literature evidence is less, but at least most of the literature is trying to match up with ACI, which is the gold standard.
Well summarized, Sashi. Well summarized.
Thank you, Sumit. So we had a good share of controversies. But points well taken, a wonderfully discussed topic. I thank the President of Indian Cartilage Society, Dr. Rajat, for this opportunity, and Dr. Panpan Chong for accepting the invitation and sharing your knowledge, and Dr. Rajat as well for sharing his knowledge, and Dr. Sumit for helping me with countering Rajat and discussing the points well. I think it was a wonderful program. Meet you again later.
Thank you.
Thank you.
Bye. Bye.
Thank you.
See you. Bye. Bye.
Bye. Thank you, Peng
Bye.
Peng.
Bye.
Thank you, Dr. John. Bye.